The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
So hello and welcome to this virtual symposium, Taking the Leap with Immunotherapy in Resectable Melanoma. My name is Jennifer Wargo from MD Anderson Cancer Center in Houston, Texas, and I'm joined today by Charlotte Arian from the Memorial Sloan Kettering Cancer Center in New York and Ryan Sullivan from the Massachusetts General Hospital in Boston. So without further ado, I'd like to get into our agenda for this presentation. First, we'll hear on understanding the evidence behind immunotherapy as an adjuvant option in stage 3 melanoma and its potential in stage 2 disease. Next, we'll hear from surgical standards to the next application of immunotherapy in the neoadjuvant setting. And finally, we'll examine a case-based exploration of how immune options have changed the management of resectable melanoma. And so for our first speaker, we have Dr. Ryan Sullivan from the Massachusetts General Hospital in Boston, Massachusetts, who will speak to us on how the immunotherapy revolution changed adjuvant therapy and wider melanoma care. Ryan?
Jen, thank you so much. I'm going to start by reviewing this slide, which has the Nccn recommendations for adjuvant therapy in stage 3 and stage 4 resected melanoma. The primary treatment for these patients will have been surgery. And then the question is, what can we do after surgery to improve the chance that that patient is cured and relapse-free? Nivolumab, which is an anti-PD-1 antibody, and pembrolizumab, which is also an anti-PD-1 antibody, have each been approved as single agents. And they are approved for stage 3A to D melanoma. It's category 1 option for stage 3B and C. For nivolumab, category 1 option for stage 3A, sentinel lymph node metastases of greater than 1 millimeter, and then also for stage 3B and C. And it's category 1 for clinical node positive for both nivolumab and pembrolizumab. They're both also approved for stage 3 in transit metastases that have been resected and for stage 4 resected disease. It's also notable that dabrafenib and trametinib, which is a BRAF and MEK inhibitor combination, is also approved for patients who have BRAF V600E or V600K mutant melanoma that's been resected for the same stages, stage 3A to D. Category 1 option for stage 3A sentinel lymph node metastases greater than 1 millimeter or stage 3B and C, and then category 1 option for clinically node-positive resected stage 3 disease as well as in transit disease. The first immune checkpoint inhibitor to be tested in both stage 4 and unresectable stage 3 melanoma as well as stage 3 resected melanoma is ipilimumab, the anti-CTLA-4 antibody. And this is data from a randomized trial comparing ipilimumab to placebo, demonstrating improved relapse-free survival and overall survival. And despite these really impressive results, this agent never really got a lot of traction in the adjuvant setting because it's associated with a significant rate of immune-related adverse events, which I'll touch upon later in this discussion. What was clear about ipilimumab data was that there was a lot of excitement about bringing immune checkpoint inhibitors from the metastatic setting into the adjuvant stage 3 setting, but that improvements could be made. And so following the anti-CTLA-4 blockade, there were subsequent studies comparing the role of adjuvant anti-PD-1 antibodies. So this trial, the Checkmate 238 study, compared nivolumab and ipilimumab placebo versus ipilimumab and a nivolumab placebo in a 1-to-1 randomized fashion. And this was for patients with stage 3B, stage 3C in the old AJCC7, and for patients who had resected stage 4 melanoma. And there was a stratification for stage, and there was a stratification for PD-L1 status. And the results are fairly striking. There's clearly an improvement of relapse-free survival for nivolumab in blue versus ipilimumab in gray. And the 3-year follow-up, which is shown on this slide, shows that there's a 58% 3-year relapse-free survival versus a 45% relapse-free survival for nivolumab versus ipilimumab. And it's important to note that benefit was observed regardless of PD-L1 status and regardless of BRAF mutation status. Here's a subgroup analysis of this data looking at the stage 3 population on the left and the stage 4 population on the right. A hazard ratio hovering around 0.7 for each of these subgroups, demonstrating really stable benefit across stage. Here's a subgroup analysis of this data across PD-L1 expression status. And here, for sure, the hazard ratio is a little lower for the patients, and by lower meaning closer to 1, for patients with less than 5 PD-L1 expression versus greater than 5 PD-L1 expression, but it's clear that nivolumab is statistically significantly better than ipilimumab with regards to improving PFS, or rather RFS, relapse-free survival, across PD-L1 expression levels. Importantly, despite the fact that nivolumab is more effective than ipilimumab, it's less toxic. And so when measuring toxicity, we can measure total toxicity, but what's a really important measure is the degree of grade 3, which we consider serious side effects, grade 4, which would be life-threatening, and grade 5, which are fatal side effects. And when we compare the grade 3 or greater side effect rate with nivolumab, it's 14% across a year of therapy versus 43% across a year of therapy with ipilimumab. And when we look at the percentage of patients, perhaps more importantly, who discontinue because of that toxicity, it was 8% on this study for those randomized to nivolumab versus 42% for those randomized to ipilimumab. And so the data continue to demonstrate clinical benefit with adjuvant nivolumab in resected stage 3 and 4 melanoma. There's clear improvement in relapse-free survival, and nivolumab, based on this data, was approved by the FDA for the treatment of this patient population. A second study has validated these findings. This is the Keynote 054 study, which randomized a similar population of patients, although this also included not just 3B and 3C patients by AJCC7, but stage 3A patients if they had 1 millimeter of micrometastasis in their sentinel node. And these patients were randomized to a year of pembrolizumab or a year of placebo. And then in an interesting trial design, this would allow for patients who recurred to be crossed over to pembrolizumab. So not only is it testing whether adjuvant therapy can improve relapse-free survival, but it's also testing or asking the question, does pembrolizumab now being post-surgery versus later, post-recurrence, make a difference in terms of improved outcomes? And the outcome ultimately of that crossover would be, do patients live longer? Here's the primary endpoint relapse-free survival Kaplan-Meier curve, again demonstrating significant benefit for the PD-1 inhibitor, in this case, versus placebo. You'll note that the hazard ratio is better when comparing pembrolizumab to placebo because ipilimumab is better than placebo. So if you could imagine the curve of ipilimumab, it would be somewhere between these two arms. And importantly, the grade 3-4 toxicity level is very similar to nivolumab, so about 14 to 15%. Also importantly, there was a treatment-related fatality. And so despite the fact that 500 patients and much less than 1% of patients had a fatal event, it is possible to die from single-agent anti-PD-1 antibodies. Here is, again, the PD-L1 positive versus PD-L1 negative subgroup analysis demonstrating similar hazard ratios for benefit of pembrolizumab versus placebo. And then here's the most updated relapse-free survival curve, which was presented at ASCO of this year, virtually, of course, demonstrating a pretty consistent separation of these curves over time. with a three-year relapse-free survival of about 64% versus 44% for placebo. It's just a slide that demonstrates that PD-1 inhibition in the adjuvant setting for BRAF mutant melanoma seems to be associated with a similar hazard ratio to wild type. Again, the hazard ratios aren't exactly the same, but they're certainly close enough, and the confidence intervals overlap quite a bit. So single agent nivolumab is certainly a reasonable option for BRAF mutated patients. This is similar data for the Keynote 054, so pembrolizumab looking at the hazard ratio of mutated versus non-mutated patients. And again, the hazard ratios aren't exactly the same, but certainly overlapping substantially in the confidence interval. So again, demonstrating that this is significantly beneficial for patients who do have a BRAF mutation and those who do not. And this is showing the relapse-free survival of Keynote 054 across all of the populations, that the significant subgroups of PD-L1 positive, PD-L1 negative, BRAF mutated overall, and again, demonstrating very similar hazard ratio. So the bottom line is pembrolizumab, whether you're BRAF mutated or BRAF wild type, whether you have PD-L1 positivity in your tumor or PD-L1 negativity in your tumor, have similar benefit compared to placebo. And when putting that together with the data from the Checkmate 238 study that shows similar benefit in BRAF mutated, BRAF wild type patients, PD-L1 positive, PD-L1 negative patients, again, there's no significant subgroup where we would say we shouldn't use adjuvant anti-PD-1 antibody for those patients. Now, whenever we have one drug, maybe we can use two drugs. So one thought in the adjuvant setting was, can we combine ipilimumab and nivolumab together? There actually is a randomized trial comparing ipilimumab plus nivolumab versus nivolumab in the adjuvant setting. It's called Checkmate 915. That trial actually did not meet it's one of its co-primary endpoints of relapse-free survival in the subset of patients who are PD-L1 negative. We'll have to see what the rest of that study looks like. But to date, there's no data with combination immune checkpoint inhibitor therapy in the adjuvant setting. But this is actually a data from a neoadjuvant approach where patients with palpable stage 3B or C disease receive 2 cycles of ipilimumab and nivolumab. I know Dr. Wargo is going to talk more about neoadjuvant therapy. And then based on what happens in that lymph node, whether there's a pathologic or near pathologic complete response, pathologic partial response, or no response, either receive adjuvant nivolumab or switch over to Braf and trametinib for the BRAF mutated. For those that have continued disease, those that had a partial response, those folks get followed, and then those who have no disease left or minimal disease left actually don't even have the complete lymph node dissection and just are followed. Importantly, combined immune checkpoint inhibitor therapy prior to surgery is associated with a significant major pathologic response rate. And again, I'll let Dr. Wargo go into more of these details about neoadjuvant ipilimumab and nivolumab, but the bottom line is it's feasible. I'd like to go on to this slide to talk a little bit more about the constellation of immune-related adverse events. We see probably 4 distinct types of adverse events. We see anything can get inflamed. So we can see, hundreds of different types of immune-related adverse events. We see 4 main categories. We see sort of annoying side effects that maybe a mild rash, a little bit of fatigue, things like that we can continue to treat through. We don't have to hold therapy. We don't have to do anything else. We see mild side effects that can be permanent, and a great example of that is thyroiditis. So about 20% of patients ultimately will have thyroid dysfunction that leads to the requirement to be on thyroid replacement. That's likely lifelong, but any patient, certainly with metastatic disease, would trade taking levothyroxine for the rest of their life versus dying from melanoma. And most patients, when we talk about this in the adjuvant setting, are willing to risk a permanent thyroid dysfunction to have their melanoma not come back. The third category are side effects that are significant enough that we have to hold therapy, maybe even reverse the inflammation with corticosteroids or other immune suppressive techniques. And the fourth are those that patients are getting hospitalized or getting IV methylprednisolone or other types of steroids, and often require second and sometimes third line immune suppression. Fortunately, that category of patients, or rather the percentage of patients that fall into that fourth category are pretty low. But it's important to note, particularly because a lot of these patients are cured with the surgery that you find surgeons are doing on these folks. It's important for our patients to know that there is these types of risks. And quite honestly, as a medical oncologist, a significant percentage of my time is spent talking about this very issue with our patients. When we think about managing these, grade 1, we tend to continue the therapy. And again, if somebody has a mild rash, we can put topical therapies. We tend to be able to manage these grade 1 toxicities without significant problems. For grade 2, sometimes we'll withhold the immunotherapy if the toxicity is persisting for a significant period of time. We'll work it up, we'll diagnose it, and then we often will reverse it with corticosteroids and may consider redosing if the toxicity resolves and it never really intensified to anything more than grade 2. For grade 3 and 4 IREEs, we tend to stop the immunotherapy. Occasionally we hospitalize these patients. Certainly for life-threatening toxicities, we hospitalize patients. And we tend to give high-dose steroids in this scenario. If the high-dose steroids work, we then taper it over 1 to 2 months until there's grade less than or equal to 1. We tend not to reintroduce, particularly in the adjuvant setting, we tend not to restart therapy and just hope that the therapy they received was good enough to prevent recurrence. If patients don't improve, we escalate to additional immune suppressive therapy. That sometimes is TNF therapy like infliximab. Sometimes that's an integrin inhibitor like vedolizumab. Sometimes it's an IL-6 inhibitor like tocilizumab, or sort of more generic immune suppressants like mycophenolate. Sometimes we often will think about prophylaxis therapy, particularly Bactrim, or to help prevent the antimicrobial diseases like PCP or PJP pneumonia. There's plenty of recommendations out there. ASCO has recommendations on managing these, and they are available. Finally, in the last minute or two, I'd like to talk a little bit about managing high-risk melanoma beyond stage 3. So though stage 3 melanoma is associated with a reasonably high risk of recurrence, so too is some of the subgroups of stage 2 melanoma. So stage 2B and stage 2C melanoma are associated with risks of death that approach 75%. The risk of death is 25%. The survival at 10 years survival is about 75%, or 80-ish% for 2B, but that actually is similar to the rate for patients in AJCC8 3A. It actually exceeds that and is similar to that in patients with AJCC 3B. So it's reasonable to think about offering adjuvant therapy for these patients. This is a trial, Keynote 716, that's randomizing patients to pembrolizumab versus placebo. It's actually completed accrual and is now in follow-up. We'll hopefully have results for this in the relative near future, but as these trials generally go, the adjuvant studies always take a few years before we have enough events where we will know whether patients are benefiting from pembrolizumab. There's an adjuvant nivolumab study that is out there. This is a trial of 1,000 patients, nivolumab versus a placebo. Again, the primary endpoint is relapse-free survival. And both of these trials are enrolling patients with stage 2B and stage 2C, so that higher risk stage 2 population. So my take-home points, adjuvant single-agent anti-PD-1 antibody therapy, either with nivolumab or pembrolizumab, is associated with improved relapse-free survival in patients with stage 3 melanoma. Adjuvant BRAF-targeted therapy or anti-PD-1 therapy is associated with similar relapse-free benefit in BRAF mutant patients with stage 3, comparing, of course, across trials. And so choice is determined by patient preference and toxicity profiles. Adjuvant anti-PD-1 antibody is well tolerated, but still may be associated with permanent, for example, that endocrine toxicity that I was mentioning with thyroiditis, or severe toxicity, which I also mentioned. And adjuvant immunotherapy is now being tested in stage 2 disease. And with that, I'll turn it over back to Dr. Wargo. Jen?
Great. Thanks, Ryan. Great presentation. And the audience actually does have a few questions. I also just, as a commentary, I wring my hands a bit when I have a patient with a stage, 2C melanoma who, if they come in, I do a sentinel node, it's negative. I wring my hands a bit because it's a bit of a conundrum. I know that they're at very high risk for relapse, so involving these patients in these clinical trials is really important. But the audience had some questions. One was, will there be a role for PD-1 or PD-L1 and BRAF-targeted therapy combos as adjuvant therapy for melanoma? And that's a subject that's near and dear to your heart. So if you could please comment on that.
So Jen, it's a great question. Of course, there is a rationale for combining BRAF-targeted therapy with anti-PD-1 or anti-PD-L1 antibody therapy. Again, it's near and dear to your heart because some of this data, the original data, was actually generated in your laboratory demonstrating that BRAF inhibitors or BRAF-MEK inhibitor combinations led to changes in the tumor microenvironment that would suggest that a PD-1 or PD-L1 inhibitor would be a good partner with those types of agents. In the metastatic setting, there are regimens looking at triplets, so PD-1 or PD-L1 plus BRAF and MEK inhibitor, and demonstrating benefit. There are randomized trials that demonstrate improved progression-free survival of triplet regimens versus doublet regimens, and one of those regimens was approved at the end of July, and that's a regimen of the PD-L1 inhibitor atezolizumab plus the BRAF and MEK inhibitor combination of vemurafenib and cobimetinib. Whether those are going to work in stage 3, we don't know yet, but there's a cooperative group trial being planned to compare a triplet regimen with some of the other standard adjuvant regimens that are out there. And really, that's the only way to know whether it's a good idea is to actually study it. And so I'm glad that trial is being designed and hopefully will move forward and be an option for a clinical trial to enroll some of our BRAF mutated patients onto it.
I think definitely tolerability and toxicity will be something to look at closely in those trials.
For sure.
Yeah. And then there's another question, since we're all living through a pandemic right now. There was a great question from the audience. For patients with early stage melanoma during COVID-19, have you been deferring or delaying surgeries? And I think, we are investigators from 3 hotbeds, New York, Boston, and Texas. And so maybe Charlotte and I can handle this one. Charlotte, I'll call on you first for this question.
Okay, so for us, I think this depended on the severity of the the pandemic, but clearly during the time when we were on complete lockdown, early melanomas were delayed. But anything that we could take care of in the office, we were doing. But as soon as we were able to get these cases on, we've definitely prioritized them, even in early melanoma. So I think the message is certainly an early melanoma can be delayed, not for a super long time. Anything we could do in the office, we did, and now we're back. Even though we still have COVID, doing these cases now.
Yeah, I think same goes here in Houston. We certainly, when we were on lockdown, delayed some cases, but now, we're back up really to full speed. Ryan, in Boston?
Same issue. There was a period of time where our ORs were essentially, closed except for emergent cases. And during that setting, actually the one scenario where the medical oncologist actually got involved was patients who had palpable stage 3 disease, and the question was, should we take them and do the normal surgery, or should we consider neoadjuvant therapy? I know you're going to talk a bit more about neoadjuvant therapy, but We took that as an opportunity to lean on some of the data that's been generated in the last couple of years, which is really exciting and supports the use of neoadjuvant therapy. Perhaps not proven to be better than standard of care adjuvant therapy, but clearly is compelling enough that we were able to justify offering neoadjuvant therapy to a handful of patients while our ORs were closed, and then we were able to get those patients into surgery about what they would have gone if they had been on one of those neoadjuvant trials.
Great. Okay. Well, I think that's the perfect segue into my talk, because we did the same thing. In Houston, where if patients came in with bulky nodal disease in the setting of COVID-19, we would often, even more so than we usually do, move to neoadjuvant strategies. And so what I'll do right now is talk about lessons from the evidence, from surgical standards to neoadjuvant immunotherapy. Now, how about the role of surgery and radiation in adjuvant melanoma therapy? And so, of course, when we're discussing lymph node biopsy or dissection versus observation, we all are very familiar with MSLT1, where we show that sentinel node biopsy was important for not only staging, but with a proposed local reduction in local recurrence. But more recently, MSLT2, or the multicenter selective lymphadenectomy trial 2, really questioned the role of completion lymph node dissection in this patient population and wanted to assess the impact of completion lymph node dissection on overall survival. And essentially what we found is that there was really no difference whether or not these patients received a completion lymph node dissection. And so the current standard of care is to do sentinel node biopsy, but not completion lymph node dissection in so-called average patients. Now, what are the data behind this? So it's not just MSLT2, which gave us this data. It was also historically before, based on MSLT1, regional lymph node dissection was offered if there was a sentinel node that was positive or there was clinically apparent lymph node metastases. However, 2 studies demonstrated that there was no difference in survival in patients undergoing completion lymph node dissection versus observation. That was the DCOG study as well as MSLT2, and the data are shown here. So pretty compelling, and I'd say this really changed the standard of care for patients with positive sentinel node. Now, how about the role of adjuvant radiation in stage 3 disease? And so adjuvant radiation has been historically offered for patients with high-risk disease with either extranodal extension, 4 or more nodes that are positive, head and neck melanomas or desmoplastic melanomas. And certainly, it did reduce the risk of local relapse, but had no impact on overall survival. And the approach really should be considered for local control and is not associated with improved overall survival. And in the setting of treatment with adjuvant immunotherapy, really you question how worthwhile is this? But again, I think there's a double-edged sword here, because now that we're not doing completion lymph node dissections, will we see an emerging role for radiation? I'm not sure. We're actually trying to ask that question and help answer that within our institution and at other institutions as well. And so the take-home message here is that completion lymph node dissection and adjuvant radiation can aid in local control, but probably don't impact overall survival. Now, how about the role of neoadjuvant therapy in melanoma? And this, again, is a really exciting area. Certainly, given the efficacy of immune checkpoint blockade, as well as targeted therapy in advanced disease, can it be used in the neoadjuvant setting? And it's certainly, and again, Ryan showed beautiful data here on the use in the adjuvant setting with survival benefit over placebo. Can we actually use this before surgery and impact outcomes? And why is this? Well, if you think about it, if patients come into a surgeon's office with bulky stage 3 disease, upfront surgery is currently considered the standard of care for patients with clinical stage 3 melanoma. However, we know that the majority of these patients, if they're treated with surgery alone, will relapse, especially prior to the use of adjuvant immune checkpoint blockade. And so, there's a real clinical rationale to use neoadjuvant therapy in patients with stage 3 melanoma. Now, why might neoadjuvant therapy be better than adjuvant therapy? And this is yet to be proven, but a couple of potential advantages. One is that the response to therapy can be determined per the individual patient. So you can actually, on a per-patient basis, determine that response, which can help guide potentially the need for additional adjuvant therapy, like that Prado trial that Ryan showed. In addition, there's the potential to reduce tumor burden before surgery. And so we're very familiar with these patients who come in, they have very bulky nodes, maybe even encroaching on vessels. You give them neoadjuvant therapy, all of a sudden they can have a really impressive reduction in tumor size, though not always. So it's a bit of a risk sometimes. You can also use pathologic response as a surrogate outcome marker for relapse-free and overall survival. Now, again, it's not been proven. We're still trying to study this, but can you actually, based on the presence of a major pathologic response, predict who's going to do better? And I think the data is starting to emerge that, yes, that may be the case. We still need to add more numbers to that. And finally, I think in the case of T-cell immune checkpoint blockade, neoadjuvant therapy could actually induce a stronger and broader tumor-specific T-cell response if you actually give it before you resect the tumor. So if you can actually auto-immunize if there's a tumor in place. Finally, there's easier baseline biomarker identification based on a more homogeneous patient population. So if you look at patients with stage 4 disease, multiple prior treatments, you treat them with a new therapy, it's really difficult to tell, whether or not the response was due to that treatment or additive from a prior treatment. So this does pose potential advantages. Now, one very interesting study that was published in the preclinical literature showed that in a model of breast cancer, at least, treatment with neoadjuvant immunotherapy was superior to treatment with adjuvant. And furthermore, it actually induced more T-cell responses against that particular cancer, and so I think there are also scientific rationale to doing neoadjuvant therapy. And so we actually launched into doing neoadjuvant therapy several years ago, and the first trial we did was a targeted therapy trial where we took patients with resectable stage 3B3C melanoma whose tumors harbored a BRAF mutation, and then randomized them to either upfront surgery or standard of care versus treatment with neoadjuvant and adjuvant BRAF and MEK inhibitors. And what we did is we looked after 8 weeks of treatment, we would restage the patients, take them to the operating room, and then they would go on to adjuvant therapy. And we collected longitudinal samples in these patients. And we did stop this trial early because there was a very strong signal and a very strong difference. What we found is that treatment with neoadjuvant BRAF and MEK inhibitors was associated with a very high RECIST response rate and pathologic complete response rate. And so you can see here that the majority of patients actually responded, which is not surprising, 85% RECIST response rate. Over 50% of patients actually had no viable tumor after 8 weeks on therapy. And when we looked at the relapse-free survival, we found that patients treated with neoadjuvant BRAF and MEK inhibitors compared to upfront surgery or standard of care actually did dramatically better. And then what we did is we actually looked at the tumor samples in these patients and found potential known and novel biomarkers of response. We found that patients who failed to achieve a path-CR had higher frequency of MAP kinase activating mutations, and they actually had a different immune infiltrate within the tumor. Though they had the same number of infiltrating T cells, the T cells were completely exhausted. So I think through these kinds of studies really highlights that, A, they can be very effective. You can learn a lot from them, not only from a clinical standpoint, but also from a translational standpoint. So next we ran a trial, a phase 2 trial looking at neoadjuvant and adjuvant immune checkpoint blockade in patients with high-risk resectable metastatic melanoma. And in this case, we took that same patient population, those with resectable stage 3B3C melanoma who did not have any brain mets or prior immune checkpoint blockade, and this time randomized them to receive either combination immune checkpoint blockade with ipilimumab and nivolumab at 3 mg per kg and 1 mg per kg respectively, versus nivolumab monotherapy at 3 mg per kg. Treated them for about 9 weeks on therapy, restaged, and then treated them in the adjuvant setting, resected, and then treated them in the adjuvant setting with nivolumab. Looked at a primary endpoint at pathologic response with additional secondary endpoints, and again, collected samples on these trials. And so, interestingly, we also had to stop this trial early, not only because there were differences between the treatment arms with regard to response, but also toxicity. And I'll go over some of that data. And note the dosing that we used here, because I'll point out a better dosing regimen. So what we found when we did this study is that treatment with neoadjuvant ipilimumab and nivolumab was associated with a higher RECIST response rate and pathologic complete response rate, and improved relapse-free survival over nivolumab monotherapy. So combined CTLA-4 and PD-1 blockade is better than PD-1 blockade alone. So we found that there was about a 25% RECIST response rate with PD-1 monotherapy. You triple that with combined checkpoint blockade, and the path-CR rate was 25% for monotherapy. You almost double that with the combined checkpoint blockade. And you can see, although it was underpowered to look for real differences here, there were non-statistically significant but notable differences in progression-free survival, distant metastasis-free survival, and overall survival in this trial. And these data were published in Nature Medicine. However, what's the hitch? And with this current dosing, with the IPI-3 Nevo 1, 73% of those patients had grade 3 or above toxicity, so very toxic regimen, whereas only 8% on nivolumab monotherapy had toxicity. And so, although very effective, also very toxic. And we did, again, look at tumor samples to look at known and novel mechanisms of response and resistance. We found that patients who had a higher T-cell infiltrate, both at baseline and early on treatment, were much more likely to respond. And those with a hot tumor were also much more likely to respond. In addition to that, we found some interesting findings. Notably, we found patients who responded to therapy had a higher frequency of actually B cells and tertiary lymphoid structures in the tumor itself, suggesting potentially some novel targets. And so now we're working with others worldwide to really understand the implications of these findings and inform next steps. That includes with Memorial Sloan Kettering, with MGH, with people all over the world, also with Ton Schumacher and Christian Blank at the Netherlands Cancer Institute. And basically, they ran a neoadjuvant versus an adjuvant trial where they gave Ipi-Nivo. And what they found is that in patients who received neoadjuvant Ipi-Nivo, they had a higher frequency of potentially tumor-specific T-cell receptors in those patients who got neoadjuvant. Again, kind of going along with those studies in preclinical models. And in addition to this, there's a group from Penn who ran a beautiful neoadjuvant study using a single dose of anti-PD-1 or pembrolizumab, where they actually found a major pathologic response rate was quite high. And they also found that in patients who had a major pathologic response, less than 10%, equal or less than 10% of viable tumor, they actually had a much better relapse-free survival. And those data were also published in Nature Medicine. And so now we're working actually with the people worldwide to form this international neoadjuvant melanoma consortium where we can really study this together. So how can we actually use strategies like this to preserve efficacy and reduce toxicity of these regimens? And this is an example of that approach. And this was work done by Christian Blank and others at the NKI, along with Georgina Long and others in Australia. And this was the Opus and Neo trial, which was recently published in Lancet Oncology, where basically the investigators took patients with stage 3 melanoma and then randomized them to one of 3 arms. And these arms included IPI 3 Nevo 1, so the dose that we had used, IPI 1 Nevo 3, or flip dosing, if you will. And then they also had an arm where patients were treated with sequential ipilimumab and nivolumab treatment. They then took them to surgery and looked not only at response, but also at toxicity. And when they did this, what they found is that the response rates were actually quite good in all the arms. And if patients had a complete response, they actually had a very high relapse-free survival. But when you looked at the toxicity summary, the rates of toxicity were actually much better in the flip dose regimen, namely IPI 1 Nevo 3. And so I can tell you that a lot of people are really adopting this dosing to really maximize the efficacy and to reduce the toxicity of this type of a regimen. And in addition to this, there are ongoing studies that are testing the hypothesis that complete lymph node dissection is not needed in the setting of a PathCR. And Ryan mentioned this study, the Prado study before, where they take patients with stage 3B, 3C melanoma and give them 2 courses of IPI 1 Nevo 3. And then if they actually just resect that index node, and if they have a complete response in that index node, they do not undergo completion lymph node dissection and are just followed. Whereas if they have a partial response, they undergo completion and are followed. And if they have no pathologic response, they have a completion and then they go on to adjuvant therapy. So it'll be very interesting to see the results of this. Again, that will be presented at ESMO very soon. This also includes strategies to combine targeted therapy and immunotherapy. And I know there was a question from the audience before about use in the adjuvant setting. Well, this combined BRAF and MEK and PD-1 or PD-L1 targeting is actually being used in the neoadjuvant setting. And this is a study out of Mayo where they're taking patients with stage 3 melanoma, treating them with either vemurafenib, cobimetinib, and atezolizumab for BRAF mutant patients versus cobimetinib and atezolizumab for BRAF wild type patients. And so I think we're going to learn a lot from these trials. Again, I think tolerability, toxicity is really, something that has been an issue with these types of trials, but I think something that we can work out over time. And finally, what do we know about the efficacy of neoadjuvant targeted therapy versus immunotherapy for melanoma? And so one of the real benefits of coming together as a community is that we can learn a lot from each other, and we can learn a lot from pooled analyses. And so as the INMC, we've come together worldwide and actually aggregated data from patients treated with neoadjuvant targeted therapy versus immunotherapy. And this is data that was recently presented by Alex Menzies and others at ASCO Live last year. There's a manuscript under review, where they took a total of 184 patients. 133 of those were treated with immunotherapy, 51 treated with targeted therapy, and looked at the outcomes for those patients as to whether or not they had a pathologic complete response, and they also compared treatment with immunotherapy versus targeted therapy. And so what did they see in a quick snapshot? And so looking at stage 3B, 3C, we saw very similar things, namely that if patients were treated with neoadjuvant immunotherapy, they actually did quite well. Targeted therapy actually also, the patients did fairly well, though, it was a bit better for the immunotherapy. And this kind of goes in line with the data in stage 4. And then when you actually compare relapse-free survival by either path CR or lack of a path CR by drug, if patients have a pathologic complete response in the setting of treatment with immunotherapy, virtually 100% of those patients survive. Again, limited follow-up here. And even if they fail to achieve a path CR, they still do quite well. But look at targeted therapy, so if they achieve a path CR, they do pretty well, but not perfect. And if they fail to achieve a path CR, the relapse risk is actually quite high. And so again, one of the things that keeps me up at night is plots like this. And I think we really need to understand this better and iterate on this and do new trials and think as a team as to how best to approach this. And so a couple take-home points in summary: I think we've made tremendous progress in the treatment of melanoma with immunotherapy and targeted therapy. These agents are now being used in the adjuvant setting with a strong rationale to use them in the neoadjuvant setting. But complexities exist regarding the optimal regimens. I think we're starting to get some insight into the optimal dosing, say for immunotherapy, but it's very clear that a multidisciplinary approach is needed with strong consideration for clinical trials. So really, you should be considering clinical trials for these patients. And then finally, we'll go to the Q&A. And so a couple of questions came in during these talks. One is, have you moved toward using extended dosing of pembrolizumab during COVID-19? Maybe Ryan, I'll call that one out to you.
So we have in select patients. So the concern I've always had with the extended dosing of nivolumab and pembrolizumab is if you don't know how somebody's going to tolerate a checkpoint inhibitor, most of the severe toxicity, at least over half, so most, does happen in the first 12 weeks. And so what I've generally done is try and in those first 12 weeks not go to the extended dosing, and then if patients are tolerating it, I feel much more comfortable about extending at that point. We had several patients who had been on pembro for a while, tolerating it well, and we converted them to extended dosing pembro as, just let's do it because of the pandemic and all the rest. But for starting somebody on therapy, we're a little more gun shy because we really don't know if there's more severe toxicity. There's probably not a lot more toxicity, but I'd hate to dose the person who's going to have myocarditis with extended dosing pembro and then wish I hadn't when they have myocarditis down the road. So we've been a little bit more conservative, but I think a lot of my colleagues across the country have gone to extended dosing pembro.
And then another great question: what is your experience of using Ipi-Nevo as adjuvant therapy thus far, similar in terms of safety to what you've seen in adjuvant or advanced unresectable disease? Charlotte, maybe I'll call out to you.
Sure. I mean, I think, obviously the toxicities, as you touched upon, are there in your talk. But as you've shown in your data, and we've also had the experience, very few people have toxicity that doesn't allow them to get to surgery. We and others have shown that, the side effects are not worse. What delays you is someone being on steroids, and that might delay you getting to surgery itself. But overall, there's no increase in surgical complications otherwise.
Great. Okay. Well, I think in the interest of time, we'll hold other questions and move on to the case presentations. And so I have the great honor next of introducing Charlotte Arian from Memorial Sloan Kettering Cancer Center, who will talk about the clinical role of checkpoint inhibitors in interdisciplinary care and the clinician-patient partnership. Charlotte.
Thank you very much, Dr. Wargo. And I have some cases that I want to present now that I think highlight some of these excellent points that have been brought up by Dr. Wargo and Dr. Sullivan. So this is a case of a patient, Laura, who's a 50-year-old architect. She presented with an abnormal mole, which was a 1.5 millimeter non-ulcerated melanoma. She has an important past medical history, which is significant for a congenital heart defect that she was born with. She had total anomalous pulmonary venous return and had a repair at a young age, and now has symptomatic bradycardia with some sinus node dysfunction and a prolonged QT interval. Other than that, she's perfectly healthy, and on physical exam has this mole without any palpable lymphadenopathy. So she underwent a wide excision and a sentinel node biopsy. She had no residual melanoma and her lymph nodes were negative, so she was a stage 1B, T2A, and 0. However, several years later, she presents back with a small palpable node in the axilla, which was FNA'd and shown to be melanoma, and she had complete cross-sectional imaging at that time, which demonstrated a 1.2 centimeter node, no other worrisome nodes, and no distant metastasis. At that time, a decision was made to proceed with an axillary node dissection where there was actually 2 nodes that were actually pathologically positive without extranodal extension. So she's a stage 3B. So at this point, her risk of recurrence is slightly larger. If you look at the AJCC survival for stage 3B, it's certainly at least 20% risk of recurrence. But if you look at the risk of recurrence, by the prospective randomized trials of, the BRAF, MEK, or the immunotherapy, actually, it seems that the risk of recurrence is actually higher in this group. And so I wonder, Dr. Sullivan, if you would just comment on what you think about the role of adjuvant therapy would be here and whether her cardiac history and QT interval affects your choice of adjuvant therapy.
Sure. So I agree that her risk is certainly greater than 20 or 25% over the next 5 years, and that adjuvant therapy is certainly worth a discussion. In terms of what her QTC or her history of a prolonged QTC, how that affects choice, I would say that most of the BRAF inhibitors can impact QTC interval. It's usually relatively mild, but in somebody who already has a prolonged QTC interval, we generally shy away from those agents. So in a scenario like this where she has an excellent option in an anti-PD-1 antibody, I think we would probably kind of lessen our enthusiasm for BRAF target therapy and be more enthusiastic for anti-PD-1 therapy.
Okay, great. That's actually what happened to her. So, so it's an interesting, point to just highlight some of the things that might point you towards immunotherapy. Okay, next we're going to go forward with the role of neoadjuvant therapy in a patient with more high-risk disease. So this is a case of Richard. He's a young 43-year-old male who grew up with a heavy sun exposure in the South in Texas without a significant past medical history. But on physical exam, he presents with a melanoma, maybe with some satellites, but certainly an advanced primary melanoma and palpable adenopathy in the axilla. So he had a biopsy which demonstrated this and had a core-needle biopsy of the axilla, which also confirmed malignant melanoma. And we have a picture of his imaging here, and you can see he has a node in the axilla and has a primary that's kind of nondescript. And the decision was made actually to start him on neoadjuvant therapy. But maybe, Dr. Wargo, do you want to comment on the role of, upfront surgery versus neoadjuvant and how you could come to that?
Right. And I think, with with all the emerging data and with now Opus and Neo and kind of really refining the regimens for neoadjuvant therapy, I think when a patient comes in like this, they have multifocal disease, maybe in transits at the primary site, high suspicion for disease, local regional disease, I think definitely image those patients. And then personally, I like to enroll these patients either on a clinical trial or treat them, if you can't get the clinical trial because of COVID, which was an issue, treat them with off-protocol, Ipi-Nevo flip dosing, and then I think you really, at least in my eyes, is that better than adjuvant? We don't know the answer yet. We haven't done that randomized trial, but it sure gives, I think, us a better shot at really kind of controlling this disease. And so that's actually exactly what was done with this patient.
And Dr. Sullivan, would this happen in Boston as well, or?
It's a Texas
So
thing.
it didn't during our shutdown. We definitely were much more enthusiastic about neoadjuvant trials. The standard of care is surgery in a patient like this, and so if we have a clinical trial open, we would certainly talk to that patient about enrolling them, and we are enthusiastic about the concept for all the reasons that Dr. Wargo was describing during her talk. There's a lot of rationale for it, but we're in the Northeast. We're a little more conservative up here. Maybe not in our politics, but definitely in every other aspect of life. And so we generally would probably have offered this patient surgery unless we had a clinical trial, and then we would have offered them neoadjuvant therapy on a trial.
I think everyone recognizes an important point is a young, healthy patient with a very high-risk disease. So Dr. Wargo, would this patient get 2 doses of neoadjuvant therapy or 4 doses before planned surgery?
2 doses. 2 doses of the flip dosing, yep. Mm-hmm.
So that is actually what happened to this patient, and the patient went on to get 2 doses, which they tolerated very well. But on the imaging, it actually looked like there was some progression. So you can see here that on the imaging, it looks like now there's several nodes that are positive, although maybe one of the nodes looks maybe a little more cystic. The one just more underneath the pec muscles there, and it was unclear what was happening with the primary either. There's some biopsy sites there as well, and so there was concern for progression, but we all know that the radiologic picture does not mirror what they see under the microscope. And in fact, this patient, when went to surgery, although there was a lot of nodes that were taken out, there was actually no tumor pathologically. It was a pathologic complete response. So. I don't know, Dr. Wargo, do you want to comment on that a little bit?
Yeah, and I think a patient like this, who comes in, who gets this neoadjuvant, especially Ipi-Nevo, sometimes you can get a nodal flare or pseudoprogression. And, I think, gosh, you can really worry and wring your hands a little bit and be like, gosh, should I take this patient to the operating room? Are they really progressing? Should we keep them on therapy? But, I think for someone like this who's got just local regional disease in a primary site, we do know that this can happen. And so, I think taking a patient like this to the operating room, really assessing for a pathologic response is really valuable, so I think that was the right approach with this patient.
This is another case of a patient with recurrent stage 3 disease that really, I think, highlights the multidisciplinary approach to melanoma, especially in this era with different effective treatments. So this is Alex, who's a 56-year-old male who presented with an advanced primary 3.8 millimeter ulcerated melanoma of the chest, but had a clinically negative exam without any palpable nodes, and actually had systemic imaging, which was also normal. And so at that time, a decision was made to bring the patient for a wide excision and a sentinel node biopsy. At the primary site, there was no residual tumor, but the patient had 4 sentinel nodes, and all 4 of them were positive. And there was more than 1 millimeter of disease in at least one of the nodes. There was no extranodal extension, but he did have a BRAF mutation. So this patient, as we all know, has an extraordinarily high risk of recurrence, but also has multiple nodes positive. And so I think that, there's strong consideration historically for further surgery in this patient versus adjuvant therapy. So Dr. Wargo, do you want to comment on how that person would be treated at MD Anderson? Or?
Yeah, no, I think that's a great question. And I think, it is someone who's got a high risk for local regional relapse, also a very high risk for distant disease. And so what's the right thing to do for this patient now? Do you get in some systemic therapy now? Do you try and take them straight to surgery and do a completion lymph node dissection? This was in the axilla, so, pretty reasonable, I think. If it was a groin dissection, I'd probably shy away a little bit more. Would love to hear Ryan's thoughts on this one, too.
It's a really important situation that we, in our tumor boards, go back and forth on. But I think with microscopic disease, we would probably aim towards getting on to adjuvant therapy, and understanding that there certainly could be recurrence in the nodal basin. That's a high risk, but as you mentioned, Dr. Wargo, this guy's pretty high risk of dying of his disease, and certainly of systemic recurrence, and so we probably move to adjuvant therapy under the auspices that's what we're treating, and we're not worrying as much about the local regional recurrence.
Right. So I think, and would you have a preference for a BRAF or inhibition or immunotherapy in the relatively young, healthy patient?
Yeah, I don't know if the relatively young and healthy matters to me. We probably offer more BRAF targeted therapy here than other places, and the reason for that is probably two or threefold. One, the toxicity that's reversible. You don't have the permanent toxicity. You treat a few patients, somebody develops Guillain-Barré or myocarditis, and you feel terrible, and you're like, why did I treat this patient who might have been cured, and led to this really awful, either fatal or morbid toxicity. With that said, obviously the risk benefit is appropriate to give this patient PD-1 inhibitor therapy or BRAF/MEK. The other reason is a little bit more theoretical. In this scenario, it's really the only place in oncology where you have a potentially curative drug in the adjuvant setting that's also potentially curative in the metastatic setting. And so that would be anti-PD-1 antibody. So immunotherapy is unique like that. We wouldn't give a woman who had metastatic breast cancer AC plus T plus tamoxifen plus Herceptin and all that kind of stuff. You treat the metastatic disease very differently than you treat the adjuvant setting. And I tend to think that BRAF targeted therapy is like ACT, meaning it's not curative so much in the metastatic setting, but it actually is curative in the adjuvant setting. So if we're thinking about the long game where we may have to offer this patient targeted therapy and immunotherapy during the course of their disease, you're offering targeted therapy at a time where it's optimal, whereas later it's not optimal. And so we often will have those conversations. Ultimately, we discuss this with our patients, and some people come in with very preconceived notions that they want to have immunotherapy, and I'm not going to talk them out of that. Some patients don't think of it at all, and I sort of present it in that fashion, and many would like to do BRAF targeted therapy. Many still are interested in the idea of sort of the cure of patient cure thyself of immunotherapy. But I think this is perfectly in the middle where it's totally reasonable offer either way. And I think the differences in how we present obviously will fashion more towards somebody choosing one therapy versus the other. But I think there's an argument that can be made for either.
Okay, great. And I think, we thought a lot about this patient as well. And, I think, looking back on those prospective randomized trials of adjuvant therapy in stage 3 disease, when broken down by disease site, there's no evidence that that by disease site, so for example, local, regional recurrence versus systemic recurrence, they all were down, So I think we thought, okay, he's got an enormous risk of having a regional, disease still in the axilla. He probably does have other microscopic disease, but, if this adjuvant therapy is going to work, it should work there as well. So we actually started him on an adjuvant therapy. He got adjuvant PD-1. And so after the first cycle of PD-1, he was imaged, and he had very small disease, but definitely disease, a new nodule that you could actually palpate on the chest wall, and the nodes, although small, were a little actually read as slightly larger by the radiologist. So we did an FNA of this chest wall mass, and it was melanoma. So clearly, very mild progression on after first cycle of anti-PD-1, and someone we're really worried about. So I think the options are to forge through with PD-1, switch to another immune therapy, switch to BRAF MEK inhibition. You could give radiation, or you could go on to further surgery. Either one of you, I don't know if you have any preference of where you would go next, but I think you probably can make a rationale for a lot of these options, and of course, the clinical trial is not listed here either. I don't know, Dr. Wargo, do you want to comment on any sense of would you feel strongly about surgery now because you knew that his regional nodes were at such high risk, and he's failing on the first immune therapy?
Yeah, and I think you could make the rationale that hopefully, the potential you've controlled the micrometastatic disease, but that if he had, these foci were definitely there in the nodes prior to initiating the anti-PD-1, and so he's kind of a setup for this. So I think now is a very reasonable time to take him for an axillary completion lymph node dissection.
Okay. All right, so we actually did do that, and 12 out of 21 nodes were actually positive. All microscopic disease, no extranodal extension. So, clearly this is a person who's a candidate for further regional therapy with radiation. He could be observed, but still we know his systemic risk is extraordinarily high. Or he has a BRAF mutation, he could get adjuvant BRAF MEK as well. So, Dr. Sullivan, do you have any preference at his next step of what he would get?
I think he's proven that his disease is pretty nasty, and I think he's still deserving of potentially effective adjuvant therapy, and so I think offering him adjuvant dabrafenib and trametinib in this setting makes a lot of sense.
Yeah. So that's actually what happened, and I can tell you that he's a year and a half out now without a recurrence. That's great. Yeah. So far it's a good example of that. So, okay, I think that's it for him, so I think we're done with our cases.
Great. Thank you, and have a great day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.